And it's always going to be difficult to follow Mike Dewar. Even though I've been here 4 times, I don't speak Spanish very well at all. And I won't even attempt to do what he did because it wouldn't be fair to your wonderful language. Just imagine, you're submitting a paper and you just have you hand draw a figure, and then people talk about it for 50 years. It's quite amazing. I wonder if they knew what they were doing. But I can tell you that I think this is the most common drawing I see in cardiology throughout the years. I think you're not allowed to give a talk on aortic stenosis unless you actually show this. And there's a reason for it, because it's really good to see how the natural history of aortic stenosis is. Of course, we'd never be able to see that again because we have so much techniques to deal with people with aortic stenosis. And most of the time when people talk about the management of aortic stenosis, just like Dr. Dewar did with mitral valve disease or mitral regurgitation, they talk about surgery. That's clearly the most in the treatment of aortic stenosis. That's the bulwark. But there's other aspects to the management of aortic stenosis. Just like I often will tell people about referrals, if you go to a barber, you'll get a haircut. So if you ask to give a talk from a non-invasive cardiologist, you're going to get a talk about the assessment of aortic stenosis. The treatment is very key, but I'm going to talk today more about before that, how to choose the people to go to the operating room, and talk more about this part of the curve. Before their symptoms, how do we look at managing these patients? How do we assess them and make sure we're getting the right people to go to the operating room? I have no disclosures. So today, I'm going to talk about 2 main points. This is just the 2 take-home points. Is how to identify the asymptomatic patients who would benefit from surgery, and then how to identify the patients with low flow, low gradient aortic stenosis. It's a particular area, which we'll get to. So there's many different ways when you're sending any surgery, but clearly something like cardiac surgery, aortic valve surgery, you look at all the risks and benefits to go from, what's the risk of the surgery, but it's also what's the risk of not the surgery and all the different factors from it. Sorry, I don't know what I'm doing to do all that. There you go. So it's important to kind of look at what is the history of these patients. And there's a lot of data out there in terms of observational data. There's plenty of studies, just going to show you a few that are showing that if you follow patients that you have in front of you, that you're going to go to surgery versus the patients that don't go to surgery, the people that do go to surgery first, or do better, sorry. That, is clearly a selection bias of who's going to surgery and not, but it's quite consistent. This was 2010, and in 2016, a meta-analysis came out pretty much showing the same thing. You don't have to look at all the specifics here, but the whole idea is that time and time again, if you have a registry, if you are looking at patients, the patients that are being assessed at that point are do better. But is that the whole story? Can even propensity match, which is attempting to do a pseudo clinical trial where you, even though it's an observational trial, you try to match the patients on a lot of different characteristics to see what it would be doing. So it's kind of a pseudo randomized bit. And again, you get very similar data that people that go to surgery do better. And even there is even some randomized clinical trial data, not too much, but there is some. So is that the end of the story? That would be easy. It sounds like, people should go to surgery. look at all the look at all this data. We should be sending everybody to surgery. This whole classic idea of waiting for them to have symptoms, maybe that's in the past. Maybe we should just be sending everybody to surgery with severe aortic stenosis. Well, some people may believe that, but most of us think there's better ways to assess that to try to identify the best patients to go. So how do we identify the asymptomatic patients? Not talking about the symptomatic patients. If you remember from that graph, once you develop symptoms, the prognosis goes way down. So these are for the asymptomatic, where you're on the narrow part of the strip, the low slope, and you don't want to operate on them too early if somebody may have 10 years before they have any problems. So how do we identify these asymptomatic patients? So we can look at our, let me see, does this have a, no. Of course, the gradient, that's the main thing we do, whether you mean gradient, whether you do peak gradient, whether you do high velocity, that's kind of the bulwark of diagnosing aortic stenosis. And clearly patients with higher gradients, if you follow them, they are going to do worse. So that's one big factor. Other factor is almost in everything in cardiology is the ejection fraction. So those are kind of our two key things. Very easy to use those, and those are critically important. And that's what we're doing much of the time. And then there's the stress tests. When I was a fellow, when we were doing stress tests for people with chest pain or shortness of breath, I think our main job was to listen to the patient right beforehand, just to make sure they did not have aortic stenosis, because that was a contraindication 25 years ago to doing any kind of stress test. But now we know that actually it can be very useful in aortic stenosis. You want to know the patients have aortic stenosis before coming in, so you can be a little bit more careful. You have different protocols and the like, but clearly patients can do it very safely. And you look at how far they go, what their symptoms are, what their blood pressure is. And if you do it with the stress echo, you can see what happens to their gradient. So that's another thing you can start to differentiate patients. And now, and more, we know in this age, there's biomarkers, the BNP, the brain natriuretic peptide, depending on how the patients are, clearing their BNP, that's will also be a factor. So that's kind of where the guidelines are pretty much now of how to use that. Let's see if I'm going to have to, LVEF is a big differentiator. Again, on the far right side, the left side, it screens the symptoms. Again, we're not talking about that. We're just talking about the asymptomatic patients. And then the far right talks about if they're already going to surgery. So we're really just talking about that one where the asymptomatic patients, and the second to the left here. So EF is very important. The velocity is very important. You can do a stress test to differentiate patients, and you can use a cardiac marker, the BNP. So that's kind of what the current state of how the guidelines are. Well, guidelines are always a little bit behind some of the other data, but this is clearly tried and true. Everybody considers it. So in addition to the biomarkers, Dr. Balsazak, as well as Dr. Curtis online, talked about the high sensitivity troponin. It's really changing a lot of different things within cardiology, mostly in coronary artery disease, but it can also be used in aortic stenosis. So not so much in the acute setting of patients for coronary syndrome, but for here, what's the troponin? How is that being affected? You can use that as well. And some even more novel within echo, strain is becoming important. It's pretty much becoming important in everything we do, certainly in cardio-oncology, certainly in infiltrative cardiomyopathies, but it's becoming more and more important in valvular heart disease, in particular aortic stenosis. So you can use strain as well. Strain is much better, much more reliable than it was 10 years ago. And you're going to be hearing about it more and more in the next 5 or 10 years. And then also cardiac MRI. for late gadolinium enhancement to look at scar. That can also determine how much this aortic stenosis is affecting the heart. So these are all different things that we can use to help us out. But so in addition to what's kind of currently in the guidelines, some other things that we can be thinking about, where troponin fits in with the BNP, where the global longitudinal strain, pretty much, I think 5 or 10 years, just from my echo standpoint, we're going to be talking about EF and strain pretty much all together. You'll think about that in everything we do. Everything you think about EF now, people are going to be talking about strain as well. It's never going to replace it, but it's going to be there. So I would think about that as well. And then how's the cardiac MRI? So these are just different ways that we can assess the asymptomatic patient with aortic stenosis. The old days of waiting until they have symptoms, we think that's pretty much gone. We want to look at these patients earlier, but not necessarily everybody, not a knee-jerk, oh, aortic stenosis, go to the OR. So there has to be a little bit more subtlety, and I think all of these things can be used to help us out. We have this whole tool chest of things from a non-invasive cardiology standpoint, the mean gradient dimensionless index on echo LVEF. And then the next stage, looking at an exercise test, whether it's exercise capacity, blood pressure, what happens when they're on the treadmill, the BNP. And then also, as we talked about, the troponin, the strain, and the MRI. Whole lot of things. You don't want to have to do this on everybody, but on your select patients that you're trying to decide. So those are important. So just to give a couple little tidbits in the future, there's an early TAVR trial that's looking out there that's using a treadmill test to look at asymptomatic patients to see whether you should be putting TAVRs in patients that are asymptomatic. And then there's the Evolved AS that uses the biomarkers as well as cardiac MRI to be looking at these patients. So there's a lot coming down the line. There's going to be tons of other studies as well to give us even a better aspect of how to differentiate these patients. So that's the one part. But even if we find the aortic stenosis, you can evaluate that. That's wonderful. But who are we missing? Here you can see the police officer saying, this is where you lost your wallet. And the guy saying, no, I lost it in the park, but this is where the light is. Oops, sorry. Yeah. So, I mean, the idea being that, yes, when we know we have aortic stenosis, certainly when you knew you had it and you were going to the OR, we had a lot of data on it. Now we're taking a step back. We know we have aortic stenosis. We're getting better at evaluating that. But here, how about the patients that we're missing? And this is where the low flow, low gradient aortic stenosis comes in. Very more difficult population from an assessment standpoint. So apologize for the cardiologists and the surgeons and other people in the room that know this. Are going to have a little bit of a primer in terms of this aortic stenosis. So the high gradient, that's typically what we're thinking about on the far right. But some of these patients don't have high gradients, and it's because they're not developing enough of a push to give them a high gradient. And typically we talk about this in low flow, low gradient AS with decreased ejection fraction. It's one on the very far left of the screen here. Then we have the paradoxical low flow, low gradient that patients that have a normal EF. There is this normal flow, low gradient AS. We're not going to talk about it too much. How much of that's an assessment issue, how much of it's a true biological. There's a little bit of controversy in terms of that. But basically on echo, the whole idea of how we get these gradients is based on conservation of mass and what we call the continuity equation, basically saying the stroke volume right before the aortic valve is equal to stroke volume right after the aortic valve. We can calculate we estimate the areas or the stroke volume by the area and then how much blood's going through it. So we basically come out with this equation. The aortic valve area is equal to the area of the LVOT multiplied by this VTI velocity time integral essentially how much blood is going through the LVOT and how much blood is going through the aortic valve. And that last part of the equation is the dimensionless index. It's just a very, very quick primer. The whole idea here is showing where the aortic valve area is not only dependent upon the gradient, but it's also dependent upon how much blood you're putting through there. What's your stroke volume? And that's what's key in terms of low flow, low gradient. If you're putting less of a volume through there, you're not going to get as much of a gradient. You know, it's if you have your hose and you decrease the flow out of it, you decrease the area out of it, yes, the gradient's going to go up through your hose. That's what we think of aortic stenosis. If you also go to the spigot and you turn it down, that's also going to decrease how far the flow goes. So that's just another way of thinking about it. Okay, so how do we do here? Without going into it, we had a fellow at Yale, Ms. Shah, and another attending faculty, Kamal Faridi, looked at all of how we do in terms of our patients. That how are we calling patients that don't have this high gradient, but do have low aortic valve areas? As you can see here from the white ones, we don't have to go through all the things, about 60% of the patients we were misdiagnosing. This is across the system. We weren't giving them even moderate to severe AS. And it didn't, this is, it's not by how much the TE volume, transthoracic echo volume, it wasn't by the years of experience, but it was by the site of interpretation. So if you're at a place that was thinking about it more, that dealt with it more, you were more thinking about it, whereas other people weren't. So it is an educatable thing. It is something you can teach people. If they're thinking about looking at it more, they'll diagnose it better. And then once it's diagnosed, you can look at this. You can go to butamine echo to see whether you increase that flow across it. Does it increase the gradient? Or if it doesn't increase the gradient, that's what's called pseudo-AS. And so the aortic valve is not opening as well as it could. So you don't necessarily need to go to the OR. And also it's big now is the coronary calcium score. This is something that's come up in the last few years. And just getting a CT to see how much coronary calcium there is. There's different cut points for men and women. Essentially, just about 2,000 for men, 1,200 for women. This can help differentiate whether this is true AS or not. Again, only on those patients that you're trying to figure out what it is. So where does that flow into? So this is just a further part of that figure I was showing. So you have the butamine stress echo here for the low flow, low gradient. And you can do coronary calcium pretty much for any of them if you're worried about it to help you decide whether they're going to do it. And there's some good data, as I showed, that suggests that coronary calcium can help differentiate prognosis. So I know it was quick, but those are the two questions that I wanted to get over today. Is just differentiating patients with asymptomatic aortic stenosis. What's their prognosis? And probably what's going to be better to send them to the OR, and how to identify low flow, low gradient aortic stenosis. And it's looking at this part of the curve, because this is where I think the big area, they've done remarkable progress in the last decades in terms of treatment of how to get things better. But now we want to try to focus, how do we get things to the OR? How do we select the right patients? And that is, will involve a team approach. No longer is this one physician making all this decision. You have a whole team trying to decide. I know we do that quite a bit at Yale, and a lot of places are going across the plates to get that team approach. And then, of course, once you have the team approach, is sharing with the patients. A lot of this has to do with quality of life. A lot of these patients are elderly, having to try to decide whether this is important. So finally, just looking at this in terms of things, so important what goes on in the OR, so important what goes on at the game time of who's doing what. It's very important to have a good game plan, but it's also important in putting the right players on the field. Thank you.